Way. My name is David Moore. I'm the Joint Clinical Lead in the Trauma and Orthopaedic Programme with Paddy Kenny. You're all very welcome to this webinar, which is to discuss the value of a virtual fracture clinic that here in Ireland is called a trauma assessment clinic. We have 4 speakers who I'll introduce as their turn comes up. Could I just ask everybody who may not be familiar with this webinar procedure, if you would please ensure that your camera and your microphone are both muted to enhance the quality of people's reception, if that's okay. If any people want to ask questions, if you can type in the question on the chat bar on the right, which you can get where it says show the conversation or hide the conversation. That's where you can put in a question, and we hope that this will be a very question and answer focused session after the speakers have given their presentations. The questions will all come after the 4 presentations, so we don't have repetition. So without any further ado, I'm going to introduce the first speaker. When we identified the concept of the trauma assessment clinics in Glasgow, we needed to have a pilot site, and Owen Sheehan very rapidly stuck his hand up and since then has really promoted the whole concept and run with it, and is currently the national lead for developing the trauma assessment clinics throughout the country. So Owen, if you'd like to go ahead, please.
Okay. Good evening, everybody. My name is Owen Sheehan. Thanks very much, Dave, for setting this up. And many thanks to everyone who's come in and participated in it. Obviously, as Dave said, questions are the important part of this. I'm going to assume most people are familiar with fracture clinics, and some people may be familiar with trauma assessment clinics, and I'm not going to reinvent the wheel. Many of you are familiar with it or are involved with it to some extent. So what we'll do is I have a couple of slides. We're going to put the slides up there, and what we'll do is we'll go through the slides. So as Dave said, the Trauma Assessment Clinic really was instituted as part of the National Clinical Care Programme in Trauma and Orthopaedics approximately 4 or 5 years ago. Tullamore were fortunate to be chosen as the site. I was fortunate or unfortunate to be chosen as the clinical advisor. So I've stuck with it since as Dave, and I have assistance from Catherine and Niamh in the clinical care office and from other clinical care programs, including the emergency medicine care program. And as well as we've involved other programs in physio and evolved. So next slide, please. Okay. So basically, it's telemedicine at its best. It's virtual fracture clinics, or what we call them, trauma assessment clinics. And there's no point reinventing the wheel. These have been pioneered in Glasgow 10 years ago and have pretty much rolled out to almost 70–80% of NHS hospitals across the United Kingdom. So we embraced it, we have copied it, plagiarized it, call it what you will, but we've also allowed people to develop their own bespoke system for it. Because there's different requirements in different units and different staffing levels, and certainly there's different IT requirements, and IT supply can vary. Some people use IPIMS, some people use Blue Spear, some people are on NIMS, and some people aren't. So we haven't given anyone hard and fast rules. But obviously, in light of the COVID-19, we've had to scale this massively in the last 6 weeks. So units that were never doing it are now almost fully functioning on it. Other units have been piloting. A lot of our co-sister hospitals in Dublin Midlands have been doing it. The Crumlin has been doing it, and Blanchardstown have been doing it. But a lot of units have come on board. Next slide, please. These are the hospitals currently doing it or attempting to set it up or have plans envisaged to get it up and running in the next week or 2. Next slide, please. So we're all aware of the fracture clinics. We don't need to push the point, really. Having 100, 120 people in a fracture clinic is no longer the acceptable norm. And certainly in light of this, with the new rules of social distancing, these are no longer possible. We have to look at virtual clinics or trauma assessment clinics as the way of delivering orthopedic fracture management into the future. Next slide, please. So Ideally, patients should be seen within 72 hours of referral from an emergency department. This is a standard, this is a guideline, and some units are up to 2 or 3 weeks. And with the trauma assessment clinic, you can get this down to within 24, 48 hours. Again, there's no hard and fast rule, but this is a recommendation, a guideline, and this is what this would be our ambition, to have people seen within less than 72 hours. Next slide, please. So this is the flow chart, really, of what happens. A person presents to the emergency department. They have an orthopedic-related injury, either a fracture, or sometimes it can be a soft tissue injury or a tendon ligamentous type injury. I won't dwell too much on soft tissue injuries, but I will dwell on fractures. And really, in the last 6 weeks, the only avenue is A, the patient is seen by the orthopedic team on call with the possibility of either admitting the patient or managing them immediately in the emergency department and discharging them. Managing them meaning managing them operatively or admitting them for observation or certain further investigations. And option 2 is referral to the trauma assessment clinic. Other options don't exist and shouldn't exist into the future if we're modernising the system of fracture care delivery in Ireland. Referred to the trauma assessment clinic can be via paper, it can be electronic referrals. And generally what happens is the trauma assessment clinic starts, we run them in Tullamore as an example. We try and run one every day where we receive referrals from the emergency department. All these charts and x-rays are collated and put together up on a system. The consultant or a senior member of staff, and we've preferentially in Tullamore tried to deliver it as a consultant-led service because the consultant is the final decision maker and has the experience to give a decision furnished with the clinical information in front of them. So the ED note is vital, and obviously the decision is largely predicated on the emergency department's assessment of the injury. So we review this, we review the x-ray or any imaging. There is on occasion the possibility of uploading clinical photographs onto the NIMS system, as well as pathological slides and all that. So it's a very vast repository that really is underutilized in the HSE. But we review all the x-rays, the notes, a decision is made, and that decision is conveyed then to the patient via a phone call. Now, some people unfortunately may not understand that, and as such there needs to be some sort of a safety net, or they have to be, or maybe brought back to a traditional fracture clinic. What we're finding now is people are either discharged directly with advice, and obviously this is courtesy of the fact that the ED, our colleagues in the emergency department are fitting people with splints, Futura splints, removable splints. Back slabs are a bad word now, basically. So they're either discharged, they're sent to a subspecialized clinic. A foot injury may need to see a foot specialist. Similarly, a hand injury may need to see the hand specialist. And we've access to occupational therapy as well, and hand specialists, hand therapists. And they're vitally important for mallet deformities and mallet injuries of fingertips. And the alternative then is physio. Now in Tullamore, we have our physiotherapy department has pretty much embraced the trauma assessment clinic and came on board very early. And considering a lot of our patients in orthopedics do need physiotherapy, it seems almost simple that the physiotherapist can take leadership and take that patient and either refer that patient to the community or do virtual assessment and virtual physio consults with the patients. So generally the patient is, what the results generally is one of the 4 there that you see in decision. An action then is calling the patient. Now, it could be a physio calling the patient. We do clinics with the advanced nurse practitioners in emergency medicine in Portlaoise Hospital, and Caroline and Joan working there will call the patients. So it gives ownership to the emergency department of the patients, and we operate almost a remote consultation system, which is the epitome really of telemedicine, certainly in the climate we're in at the moment. And Joan, or is it Caroline, I think we'll be talking later on about that. Next slide, please. So these are the splints. They're simple splints, they're disposable splints, they're understandable, and patients know how to take them off because they're quite simply put on and they're simply donned and doffed, being the expression that we're using nowadays. So courtesy of that, it's easy to explain to a patient to remove it, as opposed to a back slab, where invariably you need a plaster tech to bring them in, put them in a cast. So we're managing things a little bit differently with splints. And really this has evolved over the last 6 months and certainly has accelerated in the last 6 weeks. Next slide, please. This is a website. This is a pilot website. This is not official HSE website. This is a website we set up just to give patients information. A lot of our patients need to keep websites simple. Next slide, please. So this is the preliminary website, or the beta test website. It's orthotac.ie, and it gives advice to patients. Next slide, please. And obviously, as we go on, we'll populate this with contact details. And it's important that patients have a contact number. Initially, admin staff may receive a lot of phone calls, secretaries may receive phone calls, but over time, as there's a learning experience with this, people actually learn to accept the trauma assessment clinic, and people will ask why they're not being referred to the trauma assessment clinic or the virtual fracture clinic. And it's understandable from a patient's perspective that they have to spend a lot of time getting someone to mind their children, taking a half day off work. So there's an unseen cost and an unseen disadvantage to patients to have to attend the hospital in the numbers that they previously attended. Next slide, please. And that's pretty much it. Dave has sworn me to stick to time, so we're 8 minutes 54 seconds. So I'll hand you back to Dave.
Thank you very much, Owen. I am amazed that you actually kept to your word for time. Thank you very much. Okay, we'll move straight on now to Dr. Siobhan Maguire. Siobhan is an emergency department consultant in Connolly Hospital in Blanchardstown, and she's going to give us a perspective from an adult emergency department point of view. Siobhan, thank you very much for participating. Could I just remind everybody else, if you have any questions, you can type them in on the chat function on the right-hand side of your screen. Siobhan.
Hello, everyone. I can't see my slides actually yet. There we go. Great. Thank you. Great. As you said there, my name's Siobhan. I'm one of the consultants in Connolly Emergency Department. So thank you for giving me the opportunity to talk to you tonight. Next slide, please. So I first heard about the concept of a trauma assessment clinic sometime in mid 2018 when Paddy Kenny approached me with the concept. I was happy to get on board straight away. I was Mr. McElwain's intern back in the day, and John Quinlan was my SPR. And at that stage, I remember giving everybody the advice to not come to one of the fracture clinics unless they had a book and had had a good breakfast. So I thought there had to be a better way, but didn't have the intelligence at that point to know what the better way was. So when I heard about the concept of a trauma assessment clinic, I was perfectly happy to get on board. So like all good stories, it began with a road trip. So we headed off to Tullamore and we met Owen Sheehan, who's just spoke to you, and Sean O'Rourke, who's one of my ED colleagues in Tullamore. They both basically extolled the virtues of the concept. And so it began. And on that, I suppose, road trip, we brought all the stakeholders involved, which I think was key to our success. So myself, Paddy Kenny, our physiotherapy colleagues, we brought our plaster nurses, the ED ANPs and the orthopedic ANPs. So we all went off on this trip and came back very keen to get started. Next slide, please. So when we came back, we didn't look as elegant or as glamorous as that, but we all sat together and we kind of came up with, you know, what we thought were a reasonable list of injuries to include, based with some advice on what we had gotten in Tullamore. Our initial steps, I suppose, our caveat was that if it required a conventional cast, to make it simple, we put it into a conventional clinic. And that was kind of how we began. We met very regularly on a monthly or a 2 monthly basis, and we kind of gradually increased the list of injuries that we included to kind of ultimately come to where we are now. From October 2019, we've essentially referred everything to the trauma assessment clinic unless we feel it requires surgery within 5 days. Next slide, please. So this is just a slide including some of the injuries. So as I said, we started with some injuries, we added more, and we came to our ultimate point now, which is everything gets referred to our trauma assessment clinic. We always have the caveat that if you have any concerns whatsoever about the appropriateness or otherwise, you discuss it with the orthopedic reg on call or the ED consultant. Next slide, please. Like all good outcomes, we did have some kind of teething problems to begin with. I suppose, first of all, we had to introduce it in the emergency department, and it was a new concept, so we had to remind people of its that it was actually happening, and there'd be some clinics that would be very undersubscribed, to say the least. So we started with our NCHD teaching sessions on a Friday, and our ANPs were incredibly helpful in doing the teaching and getting everybody on board. We try and remind people at our daily kind of board rounds that yes, this was going on, and please refer patients to it. So that was one issue. I suppose our other issue was stock. As Owen alluded to in his talk, we suddenly had to have a myriad of boots and splints and things that we didn't hold vast quantities of in the emergency department. So we had to source them, and we had to find somewhere to hold them in our already overcrowded emergency department. But perhaps our biggest stumbling block was getting clerical support. We, to be honest, don't have a great IT system in Connolly, so we're still on paper systems, and the diary. So we needed to get our admin staff on board, and we had to kind of persuade them that this wasn't more work, just different work. And in the initial stages, Karen Gantley, the orthopaedic A&P, literally had to photocopy all the notes and bring them to each of the clinics. So that took a bit of time, but we did get them on board eventually. Next slide, please. So with respect to progress, we initially started with one clinic on a Wednesday morning, and then we added in a second clinic on a Friday morning. And then when we went to our current model of everything being included, we started a third clinic on a Monday morning. So the people we have attending our clinic are, we have our orthopaedic consultant, we have one of the ED consultants, we have our plaster nurses, our orthopaedic and our ED ANPs, in addition to the physiotherapists. And we try, if at all possible, to have one of our ED and CHDs present as well, because it's a really good learning for them. I suppose what's highlighted in our, at the clinics is the absolute importance of our documentation, more so now than ever, because the patient isn't there to fill in the gaps in our notes. So our documentation is critical. We also came up with the leaflet that we gave to the patients when they're leaving the emergency department of when they'll be seen, and also very importantly, a number that they can contact if they run into any difficulties. Next slide, please. This is very busy, and I can see it doesn't project terribly well, but on the left, it's just our good old-fashioned diary with a reminder to our NCHDs and ourselves of what we need to put in, namely the mechanism of injury, is the skin intact, dominance, what they do for a living, and anything else that we feel that's important, including, of course, the treatment that was given to them in the emergency department. On the right, and again, apologies, it's a photograph that I have put on. It's not great, but it's the leaflet that we give the patient leaving, and as I said, importantly, the number that they can call. That's actually our plaster clinic, is the number we have picked. We tell them to leave a message, and we assure them that we will get back to them. Next slide, please. So I suppose this is my bit to sell it, the advantages of the trauma assessment clinic. I think the advantages personally are multiple. There's advantages for the patient, there's advantages for education, there's advantages for flexibility, finance, relationships. So I suppose with respect to the patient, first and foremost, as Owen alluded to, 60% of patients can be discharged from a trauma assessment clinic, be that to our physiotherapist, our hand therapist, or indeed just back to our GP. And I suppose even furthermore, the 40% of patients that we feel need to go on to further orthopaedic clinics, they get sent to an appropriate clinic in an appropriate time manner. So for example, somebody has an undisplaced wrist, but they have been reduced and they want them seen in a week. They go to an upper limb and they're seen in a week for their x-ray, whereas if somebody else doesn't actually need to be seen for 2 weeks, well, they're not brought back in a week, which is wasting their time. So that's the main advantage, I think, to the patient. So, and as I said, alluded to in my first slide, people aren't then at unnecessary fracture clinics with huge wastes on their time. Secondly, with respect to education, as I said, we really encourage our ED and CHDs to attend, but we also learn lots. We're seeing an orthopaedic consultant. You're seeing multiple injuries in a really time-efficient manner, so it's a huge learning opportunity. The other aspect, I think, is in terms of flexibility. One example to that is we were due to have a clinic on Good Friday, and instead we moved it to the day before on the Thursday. I mean, obviously, it's much harder we don't suggest doing that all the time, but it's obviously much easier to move that type of clinic than it is to move a clinic with tons of people. I think another advantage is I think it's built up really helped enhance the relationships between ED and orthopaedics. I'm sure there's a couple of my colleagues in the audience, and I hope they don't disagree, but I doubt it. And lastly, money, the dirty word. And while we don't actually have an absolute figure on the amount of money we're saving, we know there's huge cost savings to the hospitals. Next slide, please. Next slide. So that's it. That's just basically some of the journey that we had from, as I said, our first mentioning of a trauma assessment clinic in roughly August 2018, to now 2 years in. Last year we saw, I think it was 712 patients in our trauma assessment clinic, and as I said, 60% of those were discharged without any need for any further orthopaedic input. Next slide. That's it. Thank you very much.
Okay, that's great. Thank you very much, Siobhan. Could we now just move on to our next speaker, who is Joan Dembo? You heard that Siobhan referred to an ANP who works with her in Connolly. And in fact, we find in Crumlin that the service has become very, I won't say dependent, but very supported by the ANPs there. Joan is an ANP in Portlaoise. And the perspective she has is that she doesn't have orthopedic surgeons on site to give her advice, yet she is helping to run a very, very effective trauma assessment clinic from there. So Joan, if you'd like to, you might just make sure your mic is switched on, Joan.
Yeah, this should be on now.
Yeah. Okay.
Thanks very much. Yeah, my name's Joan Dembo. I'm one of the ED AMPs in Portlaoise. And like in Connolly, we started our trauma assessment clinic in August 2018. So we're coming up for almost 2 years as well. We have a clinic twice a week on a Tuesday and a Thursday morning, which is AMP and physiotherapy run. So to start with, in our first year, we saw 328 patients, and from August last year to date, we've already seen 391. My slides? No, can't see the slides, but oh yeah, sorry. Can we go to the next? And then the next one, please. That's lovely, thanks. Initially, we started small, so only patients who had been seen and treated by either the AMP or the ED consultant were referred to the trauma assessment clinic. So for the rest of our patients seen by the NCHDs, they still attended the traditional fracture clinics. And this kind of kept our numbers quite low in our first year. But because it was such a new service and we weren't sure, where we were going with it, we started small and we built it up. We agreed a protocol with specific fractures that were suitable to be treated in the trauma assessment clinic, which are here on the screen. And basically, it was the same kind of caveat. They had to be able to be treated in a removable splint, boot, buddy strap and sling, and no back slabs. If they needed a back slab, they were sent to a traditional fracture clinic. After kind of the first year of running our service, we then decided to open it up to the rest of the patients being seen by the whole ED team. So the ED doctors were able to refer to the trauma assessment clinic as well. But again, we just stuck with the specific list of injuries. Next slide then, please. So for us, the TAC process is treated and diagnosed by either the AMP or the ED doctor. Their diagnosis is made, their splint is applied. We also have an information leaflet which we give to the patient, which explains what the trauma assessment clinic is and how it operates. It also provides the telephone number for the trauma clinic in Tullamore and the trauma clinic nurse. So if patients have any concerns afterwards, they can ring them directly. We also, at this point, confirm the phone number of patients, because this is something that we have found can be a problem if, obviously, because it's dependent on being able to contact people over the phone. If we haven't ensured that we've got the correct number, we can't run the service. We also make sure that the patients know what time we're actually going to call them at so that they're available to take a call. Our clinic is generated on IPMS and our referrals are emailed via NIMS. In Portlaoise, our TAC team is the ED AMP and the physiotherapist. The AMP presents the case. In Tullamore, there's an orthopaedic consultant, the physiotherapist and the trauma clinic nurse who review our cases, confirm a diagnosis, outline a treatment plan, which we then document in the patient's notes. Once we have finished our clinic, we contact the patients and we inform them of their treatment plan, making sure that they understand their instructions and any follow-up. And occasionally patients might have to come back to the ED for a change of a splint, or maybe to have a back slab taken off and a splint put on, or a wound review. Next slide, please. And of course, then came COVID. So in the last 6 weeks, our numbers, so all patients then, all fractures began to be treated through the virtual, through the trauma assessment clinic. So we saw over a 200% increase in the TAC referrals and almost a 500% increase in physio referrals, which obviously has been of an increased workload for us, but it has been quite successful so far. So next slide, please. So these are just some of our numbers. We just looked at the 6 weeks pre-COVID, so kind of pre-mid-March. We had seen 41 patients through this trauma assessment clinic. And out of these, 11 were discharged directly to physiotherapy. 6 needed to be followed up in some shape or form in clinics in Tullamore. Some were just to have back slabs completed, or they may have been referred to specific types of clinics. And then I know that says 35, but it should be 24 were directly discharged, requiring no follow-up. But again, we make sure that these people have the information leaflet with the contact numbers for the trauma clinic should they need, or should they have any concerns and like to speak to somebody afterwards. And now in the 6 weeks since the COVID has started, we have already seen up to the 5th of May there, 126 patients through the TAC clinic. Of these, 64 have been referred to physiotherapy. 19 have needed, again, some sort of follow-up in Tullamore, and there have been, I think, about 3 who have needed surgery, but 43 have been able to be directly discharged. Next slide, please. So for us, the major benefits that we have found after we had started the initial service, after about 6 months, we did a small patient satisfaction survey just on the first 50 patients. And we found that it was very popular with patients, mostly because it reduced the amount of time that they spent sitting in clinics, perhaps hours to be told the same thing they can be told in a phone call. They didn't have to take time off work. They weren't trying to take children out of school. It just fitted better into people's busy lives. For us, there's also been a nice continuity of care, because some of these patients that we are treating through the trauma assessment clinic, we've already seen and looked after them in the ED. So it is nice to be able to follow it through. It's been a great opportunity, you know, for learning between ourselves and working with the orthopaedic department in Tullamore. And obviously, as been mentioned before, there has been a good cost saving for the service. Now, the biggest challenges that we have found is back to communication and documentation. The clinic has to be explained properly to the patients that are going to be using it. That tends to be where the problems are. Sometimes people still think that they're going to be given an appointment to go to a physical clinic. So we need to just ensure that the trauma assessment clinic is explained properly to them. And obviously the documentation is paramount, because if we can't read what's documented, or we can't present the case, it makes it very difficult to follow people up appropriately. And then there is a time challenge with just the amount of time that can be needed to make the follow-up calls and to complete the paperwork for the clinic. But so far, again, we have managed to work with that. Okay, that's next slide. That's the end, I think, for me. Thanks very much.
That's great, Joan. Thank you very much. So our final speaker is Dr. Carol Blackburn, who's an emergency department consultant in Children's Health Ireland at Crumlin. When this clinic or service was set up in Crumlin, it was really so dependent on cooperation with our emergency department colleagues. And I think that it has been so mutually beneficial for the service, particularly the patients. So Carol, maybe you would just tell us about your experience with TAC clinics, please.
Absolutely. Thank you, David, and hello to everybody. Thanks for the invitation to contribute to the webinar this evening. So as David said, I'm one of the PEM consultants in the ED at Crumlin, and I'm going to give you a little bit of background about our experience with the TAC clinic. And I think you'll certainly find some similarities in the experience with adult patients, which is equally applicable to children. Next slide, please.
Gina HCH, the workstation.
So our hospital, for anyone who doesn't recognise it by its new name, used to be Our Ladies in Crumlin. We're a tertiary paediatric facility, and our ED is part of our standalone facilities here in Crumlin. We saw 40,000 children last year, so we are busy and getting busier every year. And of that cohort, about 20% are patients who present with trauma of one kind or another, and this distills down to about 6.5% of our total attendances are actually fractures of one kind or another. Historically, our fracture clinics, as Mr. Moore will attest to, were extremely busy and getting busier over time. And it sort of got to the point where we realised jointly, both the Department of Trauma and Orthopaedics and ourselves, and I suppose our operational services as well, we realised that we needed to find a new way to manage our trauma patients who required fracture clinic follow-up. Because the waiting times were becoming excessive. Next slide, please. So our TAC was established in August 2017, and it was opened after we had agreed a significant set of referral pathways and criterias between ourselves and the Department of Trauma and Orthopaedics. And in fact, the initial referral criteria that we agreed for the trauma assessment clinic are actually pretty much unchanged to this day. So perhaps in contrast to some other services, we didn't actually start with a very small number of patients and our small kinds of referrals and build it up. We actually started with the kind of patients we felt would be appropriate for TAC and have continued in that vein. So those would be generally children who must have a radiologically apparent fracture apart from the toddler fractures. They can't have a clinical deformity. They won't be children who've required a manipulation under sedation in the ED. And we don't refer scaphoids to the trauma assessment clinic. And we certainly don't refer any children for whom there's a clinical suspicion of non-accidental injury. But I can come back to that later. So we agreed the referral pathways. We agreed a standardized referral pro forma. So this was initially a paper document with as many tick boxes as possible to minimize free text and therefore minimize omissions, I guess. And we subsequently incorporated that pro forma into our ED information system, which is Symphony. So now after we manage a patient that we're referring to TAC, the printout referral form is automated at the end when we click the patient off. In parallel with that, we also took the opportunity to develop a pretty comprehensive injury management guideline for all of our common injuries to assist our NCHDs and our ANPs in knowing which kinds of patients to send to TAC, which might need a physical fracture clinic, and which patients in fact required a same-day orthopedic consultation. We developed parent information documents for TAC, so we have a generic parent information leaflet that gets given to every parent, and also a range of injury-specific advice sheets for common pediatric fractures. And as the previous speakers have also reflected, we needed to review our immobilization materials. And so prior to the trauma assessment clinic, we used an awful lot of POP back slabs, which of course are not designed to be left in place for any length of time. So we sourced a range of removable splints, boots, and other kinds of casting materials, and have started to use soft casts more as well for our patients to help them manage without needing to come back for a change of their splint or immobilization device. Next slide, please. So for us, the keys to success have very much been communication, and there's a number of threads to that. The first would be communication between our Department of Emergency Medicine and our colleagues in Trauma and Orthopaedics. We've had a really good collaborative process from the start. Second to that would be communication with parents. And as the previous speaker highlighted, it's really, really important that the patient, or in our case, the parent, understands what the TAC is, how it works, who will call them, when they'll call them, and what kind of advice they can expect to receive. So it manages their expectations about the service, but it also provides a great reassurance to them as to the quality of care they're actually receiving, particularly when they find out that it's a consultant delivered service in the case of our trauma assessment clinic. And also we get great feedback from our orthopaedic colleagues with regard to patients who attend TAC, both to our medical and A&P staff, and that feeds into our education process as well, which I'll mention in a moment. We've also benefited from excellent engagement in our own team here in the ED. So our nursing staff, our nurse managers, A&Ps, or NCHDs, everybody is really on board with TAC and can see how incredibly successful it's been for our patients. Our orthopaedic team have provided education sessions to our team. We have a dedicated education session which happens at our induction for new doctors at the start of every 6 months that one of our orthopaedic consultant colleagues delivers. And so at that they get, orientated to the value of the trauma assessment clinic and the kinds of fractures that are appropriate for it really from day zero. The TAC also provides an excellent condensed educational opportunity. It runs every morning here in Crumlin, Monday to Friday, at the same time in the same location. And so prior to COVID, we were able to send one of our doctors at least, and also our A&P, down to the trauma assessment clinic every morning for that 15 minutes or 30 minutes of education, which has been enormously beneficial for the knowledge base in our department in terms of managing pediatric fractures as well. Next slide, please. Oh, not sure if the screen is frozen there. Oh, great, thank you. So how do we know it works? Well, we've gone from rather lengthy waiting times for face-to-face clinics to a next weekday review for all of the minor fractures. And the knock-on benefit of that has been to free up the actual face-to-face fracture clinics for children with more significant fractures that require a timely fracture clinic appointment. We've also measured parental satisfaction. So with the permission of the hospital's Research and Ethics Committee, in 2018, we undertook a month-long qualitative study where we surveyed parents both at the time of their initial ED consultation, and then we made a follow-up call, which would have followed within about a week of their TAC appointment. And we were able to demonstrate that, in fact, we had good compliance with giving out the parental information leaflets. People rated them very highly. 92% of parents surveyed felt that the care was really very good. 100% of parents were satisfied with the education and the explanation of the service that was provided, with the benefit of them having been through the service and being able to look back at that. And interesting, we also surveyed the parents who had previously had experience of a regular fracture clinic versus the TAC, and 86% of those said, given the choice where it would be appropriate, they would much prefer the trauma assessment clinic option for their child and for their family. Next slide, please. So this is some of our data which we'd like to share. This runs from our initial TAC in August 2017 up to the end of last month. So you can see we've seen over 4,000 patients to date. The median age of the patients seen is 8.9 years, which just fits with the profile of the age of children who present with injuries in our department. 70% of those patients can be discharged after their first trauma assessment clinic consultation, so a single consultation. And then just under 25% would have required a follow-up face-to-face fracture clinic as part of their care. A small percentage, under 3%, would be referred back to the emergency department, and those would be for a variety of reasons. It might be to advise perhaps an alternative splint. It might be that perhaps we might have run out of a particular splint and it might need to be changed following on from that. Or it could in fact be for children who were suitable to have a soft cast applied, and so they would come back for that to be done in the ED on occasion. And there's a very small percentage of patients who went on to require an operative intervention following on from their fracture. Next slide, please. So for us, the strength of the service is really around it's very patient-centered. It provides patients and their parents with a really excellent service. It's delivered by the consultants. It's timely for them. There's no unnecessary visits back to the hospital. It's extremely safe because it's consultant delivered, and I suppose we have additional safety nets insofar as all of our radiology is reviewed in the emergency department by one of the PEM consultants on a daily basis as well, for a number of reasons, but it includes, I guess, picking up any injuries that might have been missed, and also patients at risk of non-accidental injury, which I'll mention briefly in a moment. The referral process is very streamlined, it functions very efficiently, and we also have the benefit of the patient information documents that we try very hard to give to every parent. So the first one being the generic trauma assessment clinic document, and then the second will be the injury specific advice sheets. And if you can pop on the next slide, please. I think I can show you examples. Oh, no, just the next one. This is fine, thank you. Just a word about non-accidental injury before I wrap up. Our department would always have had a pretty robust structure in place for being on the lookout for non-accidental injury, being a paediatric ED in the first place. So all of our staff would, of course, be compliant with Children First training. We would do specific education sessions for our trainees with regard to paediatric fracture patterns or patterns of injury suspicious for non-accidental injury. And we would educate everybody to be particularly concerned about the under 2-year-olds who are an especially vulnerable group. Our department does benefit from having one whole-time equivalent medical social worker as well. And as I mentioned briefly earlier, our NIMIS review process for all of the radiology done in our department means that a PEM consultant looks at the X-ray reports of the images themselves on a daily basis. So that's an additional safety net for us in terms of reviewing patients that have been seen the night before or the day before, and being on the lookout for potential injuries that might be of concern. We also have a community liaison nurse who reviews our attendances daily and will raise anything that they note as a red flag with us as well. And we have the benefit of being able to refer patients to public health nurses for follow-up for injuries as well. Next slide, please. So these are just examples of our documents, and they possibly aren't projecting terribly well, but the one on the left is the generic parental information leaflet, which covers the commonly asked questions for parents so that they have it in their hands leaving if there's anything they've forgotten to ask when they're with us. The sheet on the right is an example of the injury specific guidance that we use, and that one is refers to stable foot fractures. So we have a suite of those that we also give to parents when their child has a relevant injury, and anecdotally they're reported to be very beneficial for families as well. Again, I guess people don't always take in everything you're saying to them during the initial consultation, so it's very helpful for them to have a document that they can refer back to. Next slide, please. And that's me. Thank you very much.
Okay, that's great. Thank you very much, Carol. So can I just remind any of those people watching or listening that if you want to ask a question, you can type it in on the chat function on the right-hand side of your screen. I have a whole bunch of questions here that I'm going to gradually put to the different speakers, if that's okay. One of the issues is that, okay, some hospitals have been using this process before COVID, but COVID has kind of been a catalyst to expand it and develop it. But one of the ways that was able to happen was by redeployment of staff. Obviously, as COVID disappears, what will happen is those staff will maybe go back to their original roles. In order to prove to administrators and paymasters that this is of value, Owen, could I ask you to give us, a fairly detailed discussion or explanation on the cost savings that have been developed both for financially and from the point of view of the patient, because I know you've done a lot of work on that.
Okay, thanks, Dave. So we have done a fair bit of work on it, and in fairness, one of our SPRs, Christine Kiernan, did an MBA through Smurfit Business School looking at cost analysis of this, and we looked at the cost of a traditional attendance at a fracture clinic, and we worked it out that Tony McNamara was the general manager in CUH, and he worked it out in a paper published about 10 years ago. This is 10 years ago, with cost inflation not factored into it. It was about 135 euros every time someone attends a fracture clinic. So with a virtual fracture clinic, this costing is reduced to about 30 euros. Now, contemporizing it with UK data, there is a cost saving per patient attending the virtual service. Now, can I screen share there? Is that possible, Erica? Can I screen share there? My screen, is that okay?
Yeah, absolutely. Go ahead.
Okay, so I'll share my screen there with you. This is I don't know if you can see that there. It says other potential benefits. Can you see that? Has that popped up on the screen there? Hang on, give me 2 secs. Can you see that?
Yeah.
Yep.
Okay. So what we have there is that an application for funding to the government through the Sláintecare Fund, and you can see we redesign it. The immediate impact that people will see is that 18,000 new fractures are diverted away from the hospital, as in these patients are directly discharged. That is an immediate cost saving of 2 million euros, basically. In Tullamore, in the first 19 months of piloting it, we had a cost saving of about 270,000. It's very difficult to rationalize this because staffing levels maintain the same through the traditional face-to-face clinic while we were running the TAC clinic. But as Dave has pointed out, people have been redeployed out of their regular outpatient traditional service into the TAC service. And ultimately, it's looking like 50 to 60% nationally, looking at all the stats that are coming in from the various hospitals that have set it up. 60% of patients are not touching down or do not need to touch down in the clinics. So each patient is saving the HSE 80 euros. So you can work it out from there that we see on average in Ireland, on average, 55,000 new fracture referrals per annum across all our various units. And again, bear in mind that 2.3 of these people will come back again for a further attendance. So they are subsequently taken out of the loop totally. Interesting point there. I think Siobhan might have mentioned it with regard to the societal impact. And you see there that a little study we did that for the patients, the cost saving is there as well. Because people, it's very hard to cost how much time, put a value on people's time when they attend for fracture clinic appointments. But, with getting, childcare, they may have to get someone to, work for them, or they may have get someone to fill in for them at work. It's 80 euros per patient per consultation. So that's the societal cost, meaning that's what it costs society every time someone comes to hospital to have an appointment in a fracture clinic. So the costs are multiple. I mean, 2 million immediate saving from discharged patients, another 2 million saved possibly from patients that are discharged with physiotherapy, whether it be virtual physiotherapy or whatnot. So there are cost savings there. It's very obviously we have to now concern ourselves with this redeployment post-COVID, where people are being redeployed back to their original traditional clinics. I'm of the opinion that this should not happen under any circumstance, and we will try and look to the HSE for leadership and for support with regard to this, because I've spoken to a lot of people around the country with regard to this, and the overriding opinion from consultants, from ED consultants, from ANPs, physios, CNSs, the whole shebang, is that we'll never go back to the traditional face-to-face way we've ran fracture clinics in Ireland. This is the impetus or the catalyst to change this, and certainly moving forward, this is what we should be doing. I'll go back onto camera there. You can take me off screen share. Perfect. Okay, Dave.
Okay, that's great. Thank you. Thank you very much, Owen. Could I just ask Siobhan, Siobhan, one of the injuries that causes some difficulty is a query scaphoid injury. How do you handle that in Connolly?
So what we do in Connolly is, if we think the X-ray is a bit equivocal, but we're clinically suspicious, but the X-ray isn't as suspicious, we put them in a Futurist splint and we refer them to TAC. So in essence, we refer them all to our trauma assessment clinic. It's just what we do with them before that is the key. So the first one they're clinically suspicious, but not as radiographically suspicious, we put in a Futurist splint and send to TAC. The ones that we're more X-ray suspicious of, we put them in a dorsal back slab. So essentially we leave the thumb free. And probably the reason we do that, as opposed to bringing them back to our ANP review clinic, is that we just don't have ready access to MRI. So that's the main reason why we do it like that. Okay, that's great. Thank you very much.
Dawn, one of the questions that has come in is something that maybe you would answer. What do you do about a patient that you think might be somewhat cognitively impaired, that maybe they might have difficulty understanding a phone conversation at follow-up from the hospital. Have you a protocol for those? Do you send them to a TAC clinic?
Well, if the ED...
I'm sorry, that question was for Joan, if that's okay.
Okay, Joan.
If it's somebody that's cognitively impaired, but maybe have, family support systems, we will see if it's agreeable with the patient that we contact, a family member, if they're happy to receive follow-up that way. We also have access to our ED consultants review clinics that we can also refer patients back to, even from the TAC. If it's just a case of something simple, like a change of splint, or they just need, the treatment plan maybe to be explained again, they always have that option. So it hasn't really been a huge problem that we have found so far.
Okay, thank you very much. Owen, could I just ask you, there's some questions about the indemnity issue that might arise or people are concerned about. Can you comment on that, please?
Okay, so I've had a couple of inquiries with regard to indemnity, and fair enough, certainly in the current crisis, there seems to be umbrella indemnity. So I don't have direct correspondence, but I do have, if you put up my slides there, Erica, if you'd move on to, let me just see, I think slide number 15 will give clarity with regard to that. Can we do a share on the slides, please? Have you got them? You put up my slides again there, Erica. Basically, myself and Catherine Farrell, the clinical care manager, emailed Kieran Breen, and Kieran Breen is the director of the State Claims Agency. We wrote to him seeking clarity via email, just informing him with regard to the concept and what exactly we were doing. Bear in mind that the HSE are familiar with this. HSE have produced a document on virtual clinics, albeit in the last week, but we've already developed policy procedures and guidelines with regard to implementing it in Tullamore, and I know other hospitals have cut and pasted that, so there's no real, we're not reinventing the wheel here. There's no point in having perennial meetings and perennial documentation floating around. We are delighted that anyone just takes our hospital's name out of it and just puts their own hospital's name in it. We have all the documentation because we had to sort of break the earth or break the soil, literally. There's the email you can see there. I'll read it for you, for those of you that may not be able to see it because it's not quite clear. It says, thanks for your email. Please note, for the avoidance of any doubt, that the CIS, which is the Clinical and Indemnity Scheme, covers doctors and allied health professionals in, I think it's in response, or in providing the clinics described as virtual fracture clinics or trauma assessment clinics. And he just said he's impressed with the documentation, and he's happy for that email to be forwarded. So that means that we have full CIS state indemnity for this.
Okay, that's Carol, if I could ask you, would you be able to comment on, did you experience a learning curve either in the referral practice from your department or in the discharge practice of the orthopedic surgeons?
Yeah, I think in terms of the kind of patients we're referring, as I said, it's very similar to the ones we started to decide to refer at the start. The principal difference were the toddler fractures, which can sometimes be radiologically less apparent at the start. I think that we found the learning curve is probably biggest around the parental communication, making sure the parents understood the process, because many were used to coming through our service with other children and being told you'll get a call or you'll get a fracture clinic appointment on X day. And we're initially a little bit suspicious about the fact that they wouldn't need to come back and wouldn't need to have a face-to-face consultation. But over time, it's almost like the community has learned about the existence of the clinic. And now the questions come if we're not referring to the trauma assessment clinic and are in fact putting a child into a face-to-face clinic. I suppose the other learning curve has been around the pro forma that we use. We have made some tweaks to it over time. And we have, now that it's electronic, we can make some fields mandatory so that when the doctors and the AMPs are completing it, we can be sure that they, for example, I think it was Siobhan had said, the importance of our documentation is so key for our orthopedic colleagues to understand what we're describing. So we've made a couple of fields mandatory within the form, such that the form cannot be generated if they're left blank. And hopefully that then improves the experience for our colleagues in orthopedics when they're making decisions based on the information we've provided.
Okay, thank you very much. Can I just ask Siobhan, if you do you now, there's a question has come in as if a patient needs to go to a face-to-face appointment, do you make that to a particular, do you send it to a subspecialist person, or what is your protocol there? Do you just send it to the next fracture clinic?
So I suppose first off, if they're seen at the trauma assessment clinic initially, the benefit of that is then that they can be redirected to a specialist clinic. But if they just need a face-to-face one, we certainly endeavour to try to send them to a specialist one where possible, not just the next trauma clinic, next fracture clinic.
Okay, thank you. Could I just ask from the point of view of documentation, can we take it that everybody, I know that when we visited Glasgow originally, they told us not to bother reinventing the wheel, as Owen has already said, just to take all their documentation, put your own hospital logo on it. The question has come in here, where does someone get the documentation? I presume everyone is happy to share it, and if anyone who wants the documentation, just contact Owen ideally, and he'll be able to direct you. And from the paediatric point of view, you're very welcome to contact Crumlin, either the orthopedic surgeons or the ED department. Owen, could I just ask you, what about a NIMS referral? You referred to that. Someone has asked you to clarify, how do you do that?
So in fairness, Oisin Brannock, I think, is on this discussion group. So Oisin Brannock set up a referral through NIMS. It's a digital referral, but actually it's just a document, upper limb, lower limb referral. It's filled out, it's scanned on a flatbed scanner, and it's uploaded onto NIMS. In NIMS, you have this additional documentation ability. There's a facility to hold X-ray images, but there's also a facility to hold reports, and there is a facility to hold photographs and notes scanned on relevant to the patient's file. So in earnest, we actually have a facility. Now, obviously, it's only been used in certain hospitals. We've piloted it a bit in Tullamore, and I don't know if Oisin is using it in Waterford. He might be able to comment a little bit more on it, because he came up with that concept. It's a good idea. It means that we're using electronic records, but we are still waiting for this master stroke of electronic records from the HSE, so we can literally amalgamate all these different platforms and different systems we use into one unified system, which is ideally what we're crying out for here, you know.
Okay, thank you. And Paddy Kenny has just reminded me that obviously all those documents can also be got through the Trauma and Orthopaedic Clinical Programme Office, either through Niamh Keane or Catherine Farrell. Okay, so could I ask you, and sorry, Owen, for bombarding you with questions, could you tell us if you're, so we did a quick tot in Crumlin, we combined with the TALA practice, we have seen over 8,000 patients, and without going into the numbers, that's actually about 14,500 appointments, which is about the value for 65 clinics. One of the selling points is that you can free yourself up to do more work. What would you like to comment on that? What are the options when you have less fracture patients at your clinics?
Well, there's less at your clinic. Obviously, it means that you can actually afford to apportion correct time slots to people who need time. So if you have a complex patient or a non-union or something like that coming in, or a patient that needs to discuss their surgery, it means that you can apportion a lot more time, as opposed to trying to see them quickly and rush them out the door so we can get through the next 40 patients. So there's a little bit of a quality initiative to be done there as well. There's a little bit of a quality story about this as well. From freeing up time, I certainly think I looked at my practice in the first year, that it freed me up for about 20 sessions, which is 20 elective clinics. So if you see 20 extra patients in each of those clinics, maybe even if you saw 5 or 6 new patients within the Safe Clinic guidelines, you could each consultant service could potentially see another 100 new patients a year. Obviously, the problem that creates is that if we're listing them on inpatient waiting lists, it could also, in earnest, what it should do is free us up to do operating lists, which in earnest is what really orthopedic surgeons should be doing operations on patients that need operations done.
Owen, could I just ask you as well to comment on splints? How do you advise people to access the splints? Because the practice in the emergency department does need to change to facilitate the TAC clinic.
There's just a bit of an investment to be put into it at the start. I mean, what you need is a Futura, a scaphoid Futura, and an aircast walker. Body straps are simple and patients know how to remove them. They're not that complex. Back slabs really, I think, are a thing of the past. I think really back slabs are only for patients that are admitted or pre-operative patients that are going to be wearing the back slab for 24 hours. Because unfortunately, the quality of back slabs, certainly I can say that there are certain orthopedic surgeons who are unable to put on a back slab correctly. So I think it's a simplified method of dealing with injuries. No one is going to give out to anyone for putting a Futura splint on an injury, even if it's a soft tissue injury, but there will be repercussions if nothing is put on it and it turns out to be a scaphoid, as was mentioned before. That's it, really. I can see the questions actually, Dave, coming up here as well.
Okay, thanks, Owen. Could I ask each of the speakers if they have anything else they'd like to contribute? I think we've exhausted the question bank, and we have, I'm sure, all homes to go to or to get back to. Joan, can I ask you, have you anything you'd like to say to close?
No, just that we have found that our service has been very successful, very well received by patients. It's been safe. We've had very few patients that have needed follow-up outside of the trauma assessment clinic, and that, you know, it's really worked well for us.
Okay, Siobhan, anything you'd like to highlight?
All right. Sorry, can you hear me there? Yeah, I suppose the only thing I'd like to add, I think the way our model runs is that there's an ED consultant there at the clinic as well. It just means that if there is something that somehow inadvertently slips through the net, we're there and ready to take it back, you know, to the emergency department and sort it out. It's happened twice in my recollection, but just the fact that we're there, I think it just helps that flow of communication. That's the only thing I'd add.
Thank you very much. Carol, finally, anything you'd like to highlight?
No, I suppose just in conjunction with the other speakers, it's been an enormously successful clinic for us. It's solved a problem of waiting times, and it's been so much more than that. I wish there were more clinics that we could apply the same process for in terms of our patients, because we have lengthy waiting times for other subspecialties that we can't seem to address, and particularly now with COVID. This clinic is absolutely the way forward for us, for all of our patients, really, I think.
Okay, well, look, I'd like to, on behalf of all the audience, thank the 4 speakers, and I would encourage anyone who wants more information that Owen Sheehan is the point man on all of this, and information can be obtained through the College of Surgeons, the Trauma and Orthopedic Programme. That's on the website of the College of Surgeons. And finally, just before I close, I'd like to again thank the speakers, and particularly also Corey Kelly in the College of Surgeons and Erica Sullivan for setting up this webinar. So thank you, everybody, for participating. Thanks, Erica.
Thank you.
Thanks.